this is the first of a series of events really designed to bring communities, family members, clinicians, people that are interested in making change.
My day job is helping practitioners with sensible practice management strategies. And when my own children became impacted by opioid addiction, I realized fairly quickly that there was nothing sensible about the way they were being funneled out of school, out of soccer programs, off the baseball fields and into intensive outpatient programs where they were forced to call themselves addicts, where the family was divided because mothers were called enablers and codependents, and subsequently every past, present, and future digression was the mother's fault. So we slept with one eye open, we locked our jewelry in the trunks of the car, and we were advised that with every problem, with every misfire, with every positive drug test, we weren't being tough enough. So we were told to use law enforcement, that was the right thing to do. And something about that didn't appeal to me. And when I was told that my children need to work their own program, and I needed to work a program, and I walked in to Naranan, I heard one war story after another. One child had passed away. Another child was in prison for the 10th time. Yet another child was raped and lost a child because her mother wouldn't let her in 30-degree weather into the home. And I said, this is really wrong. If relapse is an expected part of this complex disorder, then why do we sanction criminally when a child relapses or a young person relapses and they go to probation and they're told that they have to be sanctioned in jail? And so many children don't show up for probation appointments. Many young women who may be pregnant don't get the help that they need. I realized that help was needed, and was I the only person that thought this way? And by the looks of things here, apparently I'm not. And I call upon everybody here to endorse in the same way, to realize, to stand up and say that no longer will we allow our children who may be experimenting only in the schools to be drug tested and funneled out of their peers and funneled away from their communities, forced to say that they're an addict when they're maybe 16 or 17 years old. I just want to let everybody know the cavalry has arrived, and thank you so much.
My harm reduction approach is based on the knowledge that human beings will always engage in behaviors that carry risks and respects a person's right to make choices. This shifts the focus from attempting to restrict or prohibit the risky behavior to reducing the negative consequences associated with them. I know that you've suffered lots of damage and poured your hard-earned resources and energy and hearts into a treatment industry that has not only failed you, but traumatizes by imposing on you a patriarchal, confrontational, one-size-fits-all treatment model that hasn't changed much in 50 years. I know this because I began my career as a traditional addiction treatment provider, trained in this mid-20th century approach, which is still used by a majority of treatment providers today. In the past decade, though, my career took a dramatic turn, profoundly affected by a couple of factors. One was personal. When my family turned to me for guidance in dealing with my nephew's substance misuse and mental health problems, I became aware of the profound flaws in my treatment approach as I watched my so-called expertise actually contribute to making things worse for my nephew and my family. Another influencing factor was professional, when young people in my practice started dying from accidental overdose. I became aware of the shameful public health policies in our country disguised as a war on drugs that criminalize and stigmatize people who use drugs. I learned that the war on drugs is really a war on our children and our families. It motivated me to learn more about substance use and its treatment as a public health issue. And when I viewed it through this lens, it was then that I learned about the value of harm reduction. Harm reduction undergirds many public health policies because it places self-empowerment of people at its center. The empowerment of substance users is lacking in traditional treatment. And it's not only lacking, but it reinforces the stigma by blaming the patient when the treatment fails, and it blames our families by giving us shameful labels like enablers and codependent. It's broken because we allow treatment to be intricately linked with law enforcement, throwing people who use drugs into a system that incarcerates them for continuing to use drugs. As a result, billions are spent each year on incarcerating users that otherwise could be spent on treatment for those who want it or need it. It's broken because rather than using science to guide its treatment decisions, it aligns itself with a moralistic, prohibition-based agenda that doesn't distinguish between substance use and misuse, and coerces people into treatment who don't want it or need it. I'm ashamed of being part of our broken treatment industry that promises rehabilitation, but avoids using established research on how to treat what essentially is a mental health condition. When people relapse with other complex problems similar to addiction that require lifestyle changes like cancer, heart disease, and diabetes, we don't blame the person for their treatment failures. We don't tell them that they're in denial, or that they need to be ready, or that they have to hit a bottom. When people relapse in treatment for other conditions, we don't throw them in jail, we don't kick them out of schools, we don't refuse them educational dollars, we don't refuse them aid for their education, and we don't throw them out of our homes without support. The future of treatment will be integrated into a comprehensive public health continuum, from drug policies that support, not punish, to early medical interventions including primary care physicians and emergency room staff, to reality-based education programs in the schools and communities for educators and parents. The future of treatment will acknowledge that teens and young adults' substance use is not assumed to be part of a disease process, but occurs in the context of a young person's process of development, and will focus on helping them to develop strategies and skills to make healthier choices and manage their emotions more effectively. Tonight is a beautiful example of the support, the passion, and the solidarity of our collective communities coming together to promote sensible drug policies. And we won't stop until our vision becomes a reality. Thanks.
Certainly Portugal, which I think has decriminalized all substances, has been, an amazing experiment that many of us are looking to see how that's playing out, and quite delighted with the results. And in the LEAD program, which I think is taking place in Seattle, if I'm not mistaken, another program just taking people right to treatment, skipping the whole prison thing if they're having trouble with addiction.
The policies of prohibition cause us to focus on the drugs. And by attacking the drugs, the people end up as casualties of war. Arrest, prisons, unresolved addictions, HIV, job loss, death. Health-centered policies place priority on the people. August Varma says this, and this is a police leader in the 1920s. Stringent laws, vigorous prosecution, and the imprisonment of addicts and peddlers has proved not only useless and enormously expensive as a means of correcting this evil, but they are also unjustifiably and unbelievably cruel in their application to the unfortunate drug victims. Repression has driven this vice underground and produced the narcotic smugglers and supply agents who have grown wealthy out of this evil practice and who by devious methods have stimulated the traffic in drugs. Finally, and not the least of the evils associated with repression, the helpless addict has been forced to resort to crime in order to get money for the drug which is absolutely indispensable for his comfortable existence. We should have listened to our forefather in policing. Over the past few decades, use has gone down for our young people with both tobacco and alcohol dramatically. How do we do that? We did it through education, we did it through treatment, we did it through social influence. That's how you do it, not through prohibition. That's what we need to do with these other drugs, heroin, cocaine, meth. We need a regulated system. We need one that's focused on health first. We need to take the $50 billion that we currently spend on cops, courtrooms, and prisons, and we need to shift that, like in Portugal, and put health first, put people first. put police at the back of the train. That's what we need. And with that money, we can provide on-demand treatment. We could have supervised injection facilities. We can start treating people who are addicted to drugs like human beings and remove the stigma. That's how you reduce abuse. That's how you get police back together with the community. And that's how we begin to move forward from here. Thanks a lot.
The first thing you want to accomplish in high school is to delay the use of any substance for as long as possible. So the earlier the substance is used, whether it's alcohol or something else, the more likely there will be lifetime problems, and the more you can delay that, the better off things will be over the lifespan. And the second goal is between 18 and 21, you want people to use as few drugs or drink as little as possible. That's also a predictor of lifetime problems. Clearly, just saying no is not going to work here. So this brings us to the issue of harm reduction, of moderation, of wise use models, of engaging with people in serious conversations about their substances and how they do that.
The laws that regulate and the way that we prohibit these substances often causes, if not equal harm, but has the potential to cause even more harm than the drugs themselves. The models that these programs that your kids are forced to sort of take, right, in school and so on and so forth, are really not based on anything sound. And that's a crime, I think, because, no parent wants their kids to be using drugs, and I think there's nothing that freaks a parent out more than having a kid who's having trouble with drugs, because there's no real sound information out there. Go online and look for something, and you're going to find all these polarized sort of arguments, right? Telling you to get tough and shaming you as a parent to take a tougher position than you might normally take, and to go against your better instincts as a parent. What do you think the rate of drug use prevalence amongst high schoolers by the time they finish high school is? 10%? 20%? 30%? Keep going up? 40%? 50%? It's about 50, 60%. If you throw alcohol into the mix, now we're talking maybe 70, 75% of kids are going to use a substance by the time they get out of high school. And, the unfortunate thing is that we don't do anything to prepare them for that ultimate encounter that they're going to have with drugs or with alcohol. So we're subjecting our kids to these needless sort of interventions, that go back to the 19th century temperance movement. And so we're fed this singular diet of sort of these tough love approaches, right? And that is driven by the fact that teens are unreasonable. They need to be scared straight. We are convinced that any drug use will snowball into problematic use of its own accord. None of these sort of approaches take into account that adolescence is a state of flux and that experimentation with risky behaviors, including drugs, is pretty normal. Instead, we seek scare tactics, resistance techniques, zero tolerance policies, random student drug testing, and all sorts of other punitive measures that are used to try to persuade, to coax, to force people to abstain. But guess what? Are kids hearing us? No other issue elicits as much gratuitous advice as having a child with a drug problem, right? If driver's education consisted of nothing more than scary video footage of pile-up accidents on the highway, no one would ever learn to drive. But what we want to do is engage them in the process of thinking about these things critically, thinking about these things as life decisions, and that they need to enter into these decisions with some intention and deliberation. If we can start accomplishing that, we're going to see less problematic use. And that's what I'm really trying to prevent, is the problematic use side of things. Keeping young people safe must be our priority, our highest priority. Abstinence only, zero tolerance approaches do not prepare young people to function in a world where they're bound to encounter drugs.
And a lot of the foundation for the harm reduction work and the harm reduction world in the United States was built on the HIV epidemic. We've actually had tremendous success in this country and in many other countries in reducing new HIV infections amongst people who are injecting drugs. But one of the innovations that came out of the harm reduction community is to step back and say, what do we know about what happens when somebody overdoses? And what do we know about what might change the outcome of that scenario? They were overdosing with their friends who they were maybe getting high with, or who were just social acquaintances that they were hanging out with. Those friends maybe didn't recognize until late into the overdose process that something was happening. And then they tried to respond. They wanted to try to help, but they didn't know how to. And there were two things that were going on. One was that they were afraid to call 911 because this involved drug use and somebody could get arrested. Maybe they were in a home where there were children that could have potentially gotten taken away. Maybe somebody was on parole. So there was this fear of calling 911, calling for help. And yet, they were not at all interested in abandoning their friends, their peers. They were trying to help. And if they just had the right information and the right tools, then maybe they'd be able to respond differently. What are some of the risk factors? That thing about mixing drugs and the situations where somebody might be especially vulnerable to an overdose because they've just been released after a period of being in jail, their tolerance is lower, or they've just gone through some kind of treatment program, some kind of halfway house where they haven't been using, and they relapse or they use again and they don't realize that amount that they were using before, their body is not going to be able to tolerate it the same way. Our major overdose problem was suddenly from these prescription painkillers. So a lot of us in the harm reduction world said, well, we've been focused over here with the people that we see, the people that we work with, heroin users. What can we do to start taking the solution that we've found in terms of equipping people with naloxone and spreading it more widely? And one of the things that emerged as the most potent set of allies for this advocacy ended up being parent and family groups. We've been lying awake at night, worrying about our kids, worrying, am I going to get that knock on the door, or my kid's not home in bed yet and it's 2 a.m., are they coming home tonight? Why didn't anybody tell us there was a solution to this fear? So these parents in Massachusetts started organizing and demanding access to naloxone. And they were instrumental in Massachusetts becoming a leader in overdose prevention. And a lot of the times it's felt like we're the voice in the wilderness. We're those kind of crazy radical people who are saying, let's just give everybody syringes, or let's maybe not lock everybody up. And suddenly we have these other voices that have a lot of credibility and a lot of emotional power behind them, who are walking this walk with us. And I think one of the lessons for me is that the harm reduction movement has been too timid in going beyond our own circles, because we have a lot more common ground with people than we think. We're seeing tremendous and very rapid public policy and public opinion shifts. We have a Republican presidential debate where a candidate talks about losing her stepdaughter to an overdose, and where we have candidates saying, I don't think we should be locking people up, I think we should be providing treatment for them. This is a massive shift amidst a much broader shift around rethinking mass incarceration and criminal justice policies. And these are dovetailing around alternatives that are grounded in public health, grounded in evidence-based treatment, grounded in harm reduction.
I think we're in a global crisis. We're not helping the majority of people with substance use issues, and the traditional abstinence-only approach is tremendously limited in its appeal and effectiveness. People don't go to traditional treatment. That's why most people in traditional treatment are mandated. So I think that we as communities and we as treatment professionals need to be grappling with this question. How can we make treatment more appealing? We're moving from simple ideas, Jelinek's disease model, reductionistic biological disease, keep it simple, stupid, toward the need for more complexity, for a more complex and more nuanced way of understanding. From biological disease, which is often a cloak for moral and criminal models, toward a psychobiosocial model. One that I think, and I'll talk briefly about, is really an attempt to integrate the idea that there are multiple vulnerability factors interacting with consequences of chronic drug use that give rise to the addictive process. We're also moving, I think, from a categorical way of understanding, that is, you have the disease or you don't, toward a spectrum model, so that we're not talking about discrete categories of problems. We're talking about a wide variability in problematic substance use. This, by the way, is embraced now by DSM-5. We see that this spectrum of problematic substance users are a spectrum of unique individuals that need unique solutions rather than one-size-fits-all treatments. So we're talking about really a new view of substance users, problematic use, and appropriate treatment. So abstinence only to harm reduction therapy. It gets expressed in substance use treatment that frequently won't treat people who don't embrace abstinence. That's abstinence only. So you don't get treatment for the problem that you're struggling with until you're ready to accept the conditions of treatment. And frequently people die before they get to that point. And on the other hand, mental health clinicians who have bought into this model come to believe that you can't treat active drug users with psychological methods. So where does that leave the active drug user who's not ready, willing, or able to stop? With nothing. And then they're blamed for it. So, what a setup for feeling worse, using more, and dying. Of course, there are receptor changes, there are neurochemical changes, but also in a society that stigmatizes and criminalizes drug use, now people become increasingly shamed and guilted and anxious and stigmatized, and as a result, many isolate. You see, the disease model said addicts, a social construction, isolate. But in the social context of drug use, people need to isolate to protect themselves. But once people begin to isolate, they cut themselves off from help, from support, from sources of positive social interaction. And all of that contributes to an exacerbation of original vulnerabilities, increased shame, guilt, anxiety, despair, and increased drug use. That's why we don't need to focus only on the substance or even on the substance to begin a process of positive change, to begin supporting people and moving in a positive direction. Therefore, we need to have treatment settings or therapeutic settings that invite people into the room while they are actively using. That is, wherever they are ready to begin the process of positive change. And that's the essence of harm reduction. So these are the basic core principles. We shift from abstinence only to any reduction in drug-related harm, which, by the way, includes the treatment of addiction, which inherently is harmful. We start wherever the patient... No, so harm reduction is not at odds with addiction treatment. Addiction treatment falls under the harm reduction umbrella. If we start wherever the person is, we can engage. It's an engagement strategy for partnering with people and offering them something that they find useful as a way to begin that process. And we embrace small incremental change rather than requiring that people make quantum change as a prerequisite. And finally, we've heard about the inherent value and power of collaboration, empowering people to become actively involved in their use. There are many well-meaning, caring, loving, dedicated people in the treatment system who are underpaid, underfunded, the programs are undersupported, they're working with old ideas, so it's ridiculous. And as the retired major was saying, there's more than enough money, but that means that part of drug policy reform needs to include, as I was suggesting earlier, treatment system reform with the dollars that will be saved so that we actually can provide quality treatment for everyone that needs it and wants it at whatever cost they're able to afford. And that needs to be a central pillar of drug policy reform.
There are good people and bad systems, and when you come from the approach that just speaks to humanity and states, wouldn't you like to have an opportunity as a probation officer to really bond, with your client rather than having to sanction them? They stop and in all cases, they say, well, yeah, I would. I've never thought about it that way. So I think the idea that we're here getting the conversation going is just really wonderful, and it's very heartwarming.
We need to continue to work towards, again, a Portugal model, where someone is discovered to have, their personal supply of drugs on them. Something happens where, they end up being introduced to law enforcement because of drugs. They need to go before a panel of healthcare practitioners, not a judge. The opportunity of a lifetime is only good for the lifetime of the opportunity. And we're there right now with this criminal justice movement. It's linked. They're dovetailed. They're joined at the hip. And we have to hold on to this momentum, not just hold on to it, but continue to build and to build until we get to the tipping point. Just like with cannabis. I think we're just about there at the tipping point for cannabis. We need to do the same thing here. And the families that are coming out now, putting a face on this issue is critical. For years, there have been faces on the other side of this issue, which have led to a lot of these archaic policies of complete abstinence and prohibition that we had. And now we're putting faces on the other side of the coin. And I just want to say just one more thing that we haven't really talked much about tonight, and that is we're dealing with a public health crisis also from the policies of prohibition, which are causing most of the violent crime that we have within our communities. We're losing a lot of lives from people who are trying to capitalize, who are trying to control corners in our impoverished communities. Those who are out there selling drugs, recruiting child after child after child into these illicit drug networks. We have to find a way, even if it's partially, to move into regulated markets. Now, what I mean by that could be a supervised injection facility like we do in some of our countries in Europe, where we provide a regulated dose. And what's crucial to that, a regulated dose, is quality control standards. A lot of what you're talking about here tonight regarding overdoses and overdose deaths, it's because, yes, the mixing of substances, but who knows how potent that pack of powder is. And it's not getting any better. When I was working undercover in 1980, 1.5, 2% pure, maybe 5% pure. Today, on average, 50 to 60% pure for heroin. Philadelphia, 80% pure. Same with Baltimore. You don't know. You don't have a clue. You don't know if it's fentanyl laced with that. As we move into this place of harm reduction and properly dealing with those who are addicted, we can shrink these illicit markets. We can make it no longer profitable for the corner open-air drug markets, which is literally selling unknown poison to people. So that's something else that we have to focus on, because shrinking those markets will make it safer for those who are addicted, and it will also make it safer for those communities regarding the competition of these many young people in our poor black, brown communities that are selling these drugs.
Could I just add one thing about the opportunity for change? In terms of the treatment system, I think we actually do have an enormous opportunity for change, because the drug treatment system has traditionally been completely outside of the rest of the healthcare system, right? As, under the Affordable Care Act and other broader transformations in how we deliver and pay for healthcare, parts of the drug treatment system are getting pulled in to that.
We've been working with Housing Works, who has the first and only OASAS licensed program in East New York, Brooklyn, that is organized around integrative harm reduction psychotherapy. And we're training their staff that range from KSAC interns to social workers to nurses. And we're also training an organization in southern rural Ohio called Integrated Services, who are bringing these, integrating these practices with both, licensed professionals, but also outreach workers who go out into rural homes, knock on doors, and engage people in harm reduction psychotherapy. So yes, we're developing models that we think can be adapted to, widely.
We call them peer health advocates. And one of the things that we do is talk about harm reduction and about how they can utilize that for both self-care as well as they develop programs for their colleagues, for their peers. And I think the model of promotoras de salud and other models that exist in terms of public health 101 out in the community, doing everything from health literacy to labor organizing, where it is that peer model. That's what naloxone does as well as the opioid overdose. It's drug users advocating and taking care of themselves and of each other. And I think we really need to bring into the conversation about how drug users have to be at the lead of this. They have to be the ones that are doing the capacity building and the organizing and teaching us. And so I think that's an instrumental part of capacity building for the future in terms of the healthcare professionals.
Everybody in this room has to step up and become a leader. I mean, that's how the world changes. That, you know, each one of you in your institution, in your community, in your city, in your state, step up and start, you know, a local harm reduction coalition office. Start having professional meetings or parent meetings or criminal justice professional meetings. We're finding as we get the message out, people are hungry for this and finding us on our website. People are tooling around looking for non-12-step or empowerment, you know, treatment or, you know, self-empowered, whatever. And it is a grassroots movement. You know, addiction treatment changes have always been driven by the grassroots.